So the outline of my presentation is what's new, what's the clinical value, and what are the next steps. Up till recently, the International Myeloma Working Group guidelines for assessment of treatment response in myeloma had complete response and stringent complete response as the best level of response of treatment. This has now changed, so I'm going to tell you something that's very important in clinical practice. I'm going to illustrate that by looking at two patients that I made up, or two patient scenarios. And this is scenario A. There are 10 patients. They all treated with this combination therapy. And you now see in front of you how they respond. They pass the red line. That's the PR line, the partial response. Some of the patients also passed the CR, the complete response line. If you look to begin with at the patient that passed PR, that's all of them. So that means that you're now looking at 100% overall response. 5 of these patients passed the CR level, so they reached, obviously, CR, 50% CR. 4 of the 5 patients with CR pass the MRD 10⁻³ level. Let's take a look at the next scenario. Here we now have 10 patients. They also pass the PR line. Therefore, you have 100% overall response. 6 of these patients pass the CR line, so you have 60% CR. As you can see, all of these patients pass the 10⁻⁵ MRD negativity line. And 4 of the 6 pass the 10⁻⁶ MRD negativity line. So what am I trying to show you here? Well, I want to put the finger on using old criteria. You have study A and you have study B. Although they are different studies and we're not supposed to compare across studies, that's what we do all the time when we look at different regimens. So let's do that together. So we can conclude that both these studies deliver 100% overall response. So they are not different. We also can conclude that the first study did 50 and the second study did 60% CR. So I guess you could say that that's not very different. And if you just use the word MRD negative and don't pay attention to the details, you can say one of them was 80, the other one was 100% MRD negative among the CR patients. And I guess you could say that's not very different. But I just show you they are very different. Scenario B has a much deeper response. We know that every CR is not the same. There is low-level disease that is flying under the radar. And that's exactly what this presentation is all about. So we have had for a long time ability to detect low-level disease in other disease areas with flow cytometry, and increasingly so, we have started doing that in myeloma. We also have access to sequencing-based technologies that can detect low-level disease. There's been a lot of discussion which of these two that we shall use in myeloma. And just to give you a few details on these two technologies, if you use flow, it's probably close to 100% available around the world, flow machines. If you do it right, you can find one cell in 100,000. That's 10⁻⁵. It's not easy to do it right. There are pluses and minuses. The main limitation when it comes to doing it right is that each lab have their own favorite antibodies. They have their own way of processing the sample. There is no one standardization around the world when it comes to flow cytometry for the purpose of MRD in myeloma. Good things with flow for MRD testing in myeloma is that it has a short turnaround time. You take the fresh sample, you send it to the lab, and you get results even the same day or the day after. The problem is that the results are not very generalizable. You don't need any baseline sample, so that's a strength also. Looking at the molecular tests, it has lower applicability because it's not as available yet. That will change. It has higher sensitivity. It can detect one cell in a million. The strength here is that you don't need a fresh sample. You can bank samples. You can send fresh samples as well. I already showed you that it's more sensitive than flow, and it's not as operator dependent. It's much more reproducible. Downside is that you need a baseline sample, and currently this technology is not yet as available. I do predict that within 1 to 2 years, we will have this technology everywhere, and we will be able to run it in local places. Importantly, on a clinical note, the International Myeloma Working Group guidelines were published this summer, and they include MRD for the assessment of treatment response in multiple myeloma. So this is clinically important. The guidelines say, in order to call a patient MRD negative, there are 2 things that need to be true. The first is that the patient needs to be in complete response. In a patient that is in complete response, you then have to take that bone marrow aspirate and you have to use a test that can rule out 1 cell in 100,000, or 10 to minus 5. If you do that, then you can declare MRD negativity. You can use either flow or you can use sequencing-based technologies. So what's the clinical value of this? Why has this changed in the field of multiple myeloma? The reason is that it translates into longer clinical outcomes, and I'm going to show you that. We just published a meta-analysis where we searched the literature for all published studies that have looked at MRD negativity and positivity in multiple myeloma that focused on newly diagnosed patients and had information on progression-free and overall survival. This study shows, and it's available online, that there are, or actually I should go back and tell you about the methods. This is how we searched for the papers. We looked in Medline, Embase, and Cochrane's Central Register for Controlled Trials. The study shows that MRD negativity is associated with a hazard ratio of 0.35. So there's a 65% reduced risk of progressing if you are MRD negative. The study also shows that if you turn MRD negative, you reduce the risk of dying by 50% based on this meta-analysis. I think this is very important. There are a lot of limitations, obviously, with the meta-analysis. The meta-analysis never gets better than the original data that goes into it. So ideally, prospective studies should capture information on MRD for every patient using the best technology for MRD, and also capture progression-free and overall survival and assess the correlation. And those studies are ongoing. There are very many clinical trials in myeloma that do capture MRD. So I think in the coming few years, we will see very strong data in this particular area. Is MRD more important than therapy? I'm not sure, but maybe. So this is from the determination trial that was designed to assess patients that received 3 cycles of Velcade-Rev Dex, followed by 5 more cycles on the left. They collected their stem cells before they went on to the 5 cycles, and then they got maintenance. And on the right, they collected the cells, they got autologous stem cell transplantation with melphalan 200, and 2 more cycles of Velcade-Rev Dex, and 1 year of maintenance. The study was designed to compare arm A to arm B, and the winner was presented at ASH, this past ASH. That was the transplant arm. It had a better 3-year PFS, 61%, versus the non-upfront transplant arm, 48%. There was another presentation at ASH by another author from the group showing that this was driven by depth of response. There were more patients obtaining a complete response in the transplant arm versus the delayed transplant arm. And also as part of that second presentation at ASH, the results were broken down by MRD status. So although the transplant arm is the winner for progression-free survival, that is the primary endpoint. Looking at this study broken down by MRD status, you can see that there are patients that obtained MRD negativity on both arms, and they have about the same progression-free survival. This is not the primary endpoint. The numbers are smaller. It's not definitive data you see in front of you, but it raises the question whether myeloma will be another disease where the results of the response are more important than the therapy, such as we have seen in CLL and ALL and other diseases as well. I think this is very interesting. So if we believe in these hypotheses, I think it's reasonable to at least ask ourselves, how shall we treat patients going forward? Should we have predefined chemo-transplant number of cycles, or should we try to tailor treatment by response? So these are questions that are now on the table. Going forward, what are the next steps? Here are a couple of perspectives that I would like to share with you. I think measuring MRD negativity, I've showed you it's associated with better progression-free and overall survival. But what about being MRD negativity longitudinally? You maintain MRD negative. It's probably better if it doesn't come back. I guess one could conjecture that this could be a stepping stone eventually for some curative treatment, but probably also is associated with better long-term clinical outcome, even if it doesn't deliver cure. We need to study this. I share with you some data from the study that I led when I used to work at the NCI, and we have just updated this study, and we will be presenting more details on this topic at ASH coming up soon. We treated 45 multiple myeloma newly diagnosed patients. So these are not smoldering patients. They are newly diagnosed myeloma patients. They all received 8 cycles of carfilzomib, Revlimid, dexamethasone, and then they were put on Revlimid maintenance for 2 years. And what you can see here is after 8 cycles of combination therapy, 44% of patients are MRD negative, 10 to -6 actually. After 1 more year of maintenance, interestingly, out of the 20 patients, out of the 45, there were first 20 that were MRD negative. You see that there are additional 3 patients that go into MRD negativity during maintenance. I think that's interesting. It's not surprising at all to me, monitoring many patients that have low-level disease. I think continued therapy can continue to drive down the disease. And also, you can see after 2 years of maintenance, which is almost 3 years out, 46% of these patients are MRD negative. That's almost half the patients. The youngest patient was 40 years, and the oldest was 88 years old on this study. So these are quite interesting data. It's a phase 2 trial with 45 patients. The guidelines by the International Myeloma Working Group include definitions for the sustained MRD negativity. So I already showed you how to determine MRD negativity. You have to be CR, and you have to have an assay 10 to -5. If you want to call the patient sustained MRD negative, you have to repeat that MRD test after a minimum of 1 year. You can also do subsequent evaluations, and you can talk about 2-year, 3-year, 4-year, 5-year, etc. MRD negativity. And I just showed you from our own study, almost 3 years out, that there was close to 50% MRD negativity. What does it mean if patients go from MRD negative back to positive? We know much less about it. I do think this is going to become an increasing phenomena that we will start seeing in this field. There is not a whole lot of information. This paper shows that for patients that go from MRD negativity back to positivity, the lag time on average in this study was 9 months between reappearance of MRD and then the need for salvage treatment. In my clinical practice, that's about the same. I think it goes from 6 to 18 months. I think we will see more drug development in this space going forward. What about imaging? Can that be used for MRD testing in myeloma? In the International Myeloma Working Group guideline, it is part of it, but I would like to bring up a couple of limitations with PET-CT in myeloma. It has high false negative rates. Patients with multiple myeloma are not always SUV positive. Probably 30% or so are negative. There's a lot of false positive. We all know when we image even a person who claims that he or she is healthy can light up in joints or in muscles or for infections or things like that. So a lot of false positive. Also, the definition of what is SUV positive varies from paper to paper. So as you know, you compare to the baseline in the individual patient. There are papers saying that if you have a 50% increase from baseline, they call it positive. Other papers claim that you have to have 100% or more, and the literature is not consistent. The timing of PET-CT has varied across the few studies there are for myeloma, and importantly, FDG has not been developed for myeloma. Independent of these drawbacks, MRD negativity by PET-CT is described in the guidelines, and they say if you are negative by flow or sequencing and you do PET-CT as well and there is no abnormal uptake, you can claim imaging MRD. But I think we know very little about the value of that for right now. I want to round off my presentation by also mentioning some real data information on MRD testing in the country. So we conducted a survey on the use of flow cytometry for MRD testing in myeloma in 2013. We asked the 30 leading centers in the US, do you conduct MRD testing for myeloma? And 11 said, yes, we do. We now asked again last year, and 14 said. So 14 out of 30 said yes. If you look at the guidelines and the consensus documents on how to do it, the numbers are actually different. There are not 11 centers that did it in 13. There's only one center that did it right. And last year, there were 6 centers that did it right, if you apply the consensus for how many events you shall use. If you look at the consensus for limit of detection, there were 2 centers that did it right, and now 6 centers. So my message is that there are not very many centers right now that do flow. So I think as soon as sequencing technology comes out, I think that will be game-changing. Also, I want to mention the use of monoclonal antibodies, because we use proteins in the blood to monitor the disease as a biomarker, the M spikes. These drugs are similar to the M spikes. They are IgG kappa proteins. If you give any of these drugs to a patient or even a healthy person, you will see a band in the serum. So you will see false positive bands. It's not disease, it's drug. If the patient has IgG myeloma, if you don't know what you're doing, you don't think that you eradicate the disease, but you're looking at drug. There are ways around it. There are a lot of limitations with those ways around it. This is not yet a clinical problem because these drugs are not yet approved for the upfront treatment, but I think this is going to be something we have to deal with. Practical steps going forward, future steps. We need MRD as a regulatory endpoint for drug approval in myeloma. If we are not if you're not being able to get MRD approved as a regulatory endpoint, I do think drug approvals will stop for the newly diagnosed setting. We need to have a surrogate endpoint that then can be followed by a PFS that will deliver regular approval. And I think this will probably happen within 2 years here in the US. Future other steps is, if you obtained MRD negativity, positivity, shall we think of developing trials where we can actually drive the treatment based on the response? So here's one example of an idea. You could treat, you could check for MRD, and if the patient is negative, maybe you could think of offering the patient going right to maintenance, or you could go to consolidation with additional transplants and then maintenance. And obviously, I don't have the hard data to prove that this is right or wrong, but these are ideas. For patients that are positive, you could go right to the conventional therapy, or you could have some experimental loops. And these are just examples of how you could think of using a biomarker for treatment decision. I guess you could also think of it the other way around. If you maintain negativity for a long time, could you even think of stopping therapy? So in clinical practice, we don't have any evidence, we don't have any data to support that you shall stop therapy. But I think for trials, similar to what has been done, for example, in the CML field, I think this needs to be investigated in myeloma as well. Also for patients that do remain MRD positive, capturing those residual cells and trying to understand what makes those cells survive and maybe try to eradicate those also is a new avenue. So to summarize, MRD negativity is associated with better outcomes, both progression-free and overall survival in newly diagnosed myeloma patients. It is defined by the International Myeloma Working Group criteria, and it should be included in clinical trials going forward. MRD negativity is more important than treatment given to become MRD negativity, ? I think this is an important question we need to address. So what are we thinking about at Memorial when we have nothing to do? Well, I think that we need to think about other ways of capturing MRD. I think blood-based tests and urine-based tests would really change the game. We are working on this, and there are other groups around the country and internationally working on this. I think we're going to get there, I think, in a few years from now, and I think this really will change the whole field. Ideally, I think we need something like this. With that, I would like to thank my collaborators at Memorial and our external collaborators, and I'd like to thank you for your attention.